here I'm going to talk about status epilepticus. Status epilepticus is mainly defined by seizures that are lasting more than 5 minutes. You might see some definitions that differ with this definition, or basically not differ, but some alternative definitions that also said that a patient that is seizing for more than 30 minutes but has some periods uh, free of seizing but do not return to their basal state. This is also status epilepticus, but the most accepted definition is this one that I put here, which is seizures lasting more than 5 minutes. This is status epilepticus, and it has a high mortality rate between 19 and 27% within the first 30 days after presentation, but there are some series that report lower mortality rates. This is only for status epilepticus. Keep in mind that isolated seizure, an episode of seizures that last less than this, uh, really has lower mortality rate, very low. So this is only true for status epilepticus. The most common causes of status epilepticus, well, status epilepticus most often presents in patients that have had previous episodes of seizures. And the most common cause is because they skip their medication, or because they have some infection or something that triggers these seizure episodes. And in some patients, the episode is going to remain idiopathic. Also, something important is that low blood glucose levels are associated with status epilepticus, and also very high blood glucose levels are associated. So this is why in any patient that is presenting with status epilepticus, we might want to take a blood sample to rule out this cause. And in children, mainly, fever is an important precipitating event. Okay, what about the pre-hospital treatment of status epilepticus? Um, well, it is important to keep in mind that the sooner we start the treatment, the greater the chance that we have for terminating status epilepticus. And the treatment of choice, we know it's benzodiazepine, but we are going to see more about this in a few slides. Okay, so we see that if we start treatment in the first 30 minutes, we have a more than 80% success rate of terminating with the status epilepticus. Even though if we delay started treatment after 2 hours, the success rate reduces to about 40%. So I want to show you here how important it is to start treatment soon. And traditionally it has been diazepam, the drug of choice, but in the few years we have seen some changes uh, that point towards use of lorazepam or midazolam. Okay, um, so in pre-hospital setting, the agent of choice is going to be midazolam, 5 milligrams in children and 10 milligrams in adults. Why this? This is mainly because when the patient presents with the status epilepticus, at the beginning we usually don't have an intravenous line in place, and we can administer midazolam intramuscular. We also can administer diazepam rectally, or we have another options, but there are some reports that say that midazolam stops seizures sooner than diazepam. So uh, some organizations say that we should begin with midazolam, intramuscular midazolam administration in patients that are presenting with status epilepticus, especially in the out of the emergency department. And here I put an algorithm that we can follow so it is easy to know what to do in a patient with status epilepticus. First, we detect the patient with status epilepticus. By history, we know that he has been seizing for more than 5 minutes. So, in the pre-hospital setting, uh, they're gonna administer uh, midazolam, 5 milligrams in children, 10 milligrams in adults. Then, when he presents to the emergency department, if he's still seizing, the next most appropriate option is lorazepam 4 milligrams. We are going to do this approach if either if the patient received the midazolam treatment or not. We're going to administer 4 milligrams of lorazepam. But if the patient had received the previous dose of midazolam, after administering the 4 milligram dose in the emergency department, if the patient is still seizing, we are going to pass to the second line agents. But if the patient didn't receive midazolam in the outpatient setting, we can repeat the 4 milligram dose after 5 to 10 minutes. And if the patient is still seizing, we continue with second line agents. And here are the second line agents, the preferred agents. Phenytoin and phosphonitoin are the preferred ones, but there are not randomized controlled trials that have compared between these agents' effectiveness, so we can use any of these. Keep in mind that levetiracetam is a frequently used option, but is not approved by the FDA. I'll leave you here this table or these different options so you can pause the video here and see how they are administered. Okay, and if we stop the seizures with these second line agents, there are some important things that we might look for. As we said, the most common causes of status epilepticus are due to patients that are known to be epileptics but are not taking their treatments, or patients that are having some infections. But we want to see if that's the cause, and we have to take some labs. We want to pay special attention to blood glucose. We can take computerized tomography in patients we believe that have a structural cause of that is precipitating the seizures. This is especially true for patients that have a focal deficit. We also want to see a urine toxicology screening, metabolic panel, and electroencephalogram. Um, this is very important because we can, by obtaining an electroencephalogram, we can see if the patient has a non-convulsive status epilepticus also. And in sometimes we can obtain a lumbar puncture. Keep in mind that if we're going to do a lumbar puncture, we might want to have a imaging study previously, so that we know that the patient doesn't have a mass or something that puts him in risk of herniation. And the lumbar puncture is mainly to rule out neuroinfection. And what about refractory status epilepticus? If the patient doesn't respond to any of the previous treatments, including the second line treatments, this is considered refractory status epilepticus, and refractory status epilepticus is treated with drug induced coma, and we have to intubate the patient. And in these patients, it is important to continue with electroencephalogram monitoring, because we might not know if he is still seizing or not since he is sedated. So we want to see if he has a non-convulsive status epilepticus. Okay. Uh, well, here are the most used regimens for drug-induced coma. The two preferred options are with midazolam and propofol. I'll leave you here the doses and how they are administered. Okay, and there are some special considerations that we might keep in mind. In children, we basically treat the same way as in adults, but we have to keep in mind that propofol is not very recommended in children because it is associated with propofol-induced syndrome, in which patients present with acidosis, with rhabdomyolysis, and it has a very high mortality rate. So if we can give children midazolam, that's a better option. Also, in some children, especially neonates or children under 2 years of age, um, status epilepticus is often associated with a defect in with a defect in uh, pyridoxine metabolism. So we might consider administering pyridoxine. And also in patients in which the seizure episode is associated or might be associated with isoniazid treatment, pyridoxine is an option. Um, well, I guess this is the most important points to talk about in status epilepticus, and I hope you find it helpful. Thank you.